Okay, this is a little bit louder, right? So, during your rotation, like either in retina or in inflammation uveitis, you're going to come up with this term called white dot syndrome, which is a constellation condition that we don't know anything about yet fully. That's why it's called syndrome retinal disease. And some people think it's a spectrum of disease from one end to the other. Some think a bit more distinctive. So this is like a fun talk for you to be able to recognize which one is dangerous, which one is not, and I will go of this aspect here. So let's say we move forward. Some disclosure here, I serve on a number of advisory committee and share several studies with this, so that's how university receive funding for various aspects. When we look at white dot syndrome, by the way, what is the lower end here, Dr. Park? The picture in the lower right? Which of these would you like to pick?
Could be birdshot.
Yes, so that's just the right end. So that's the first case of birdshot. That's a very classic. So a lot of ophthalmology disease are based on pattern recognition. The case on the lower right is the case of birdshot in this aspect here. But when we look at the white dot syndrome, you will see a number of conditions. Birdshot being mentioned, multifocal choroiditis and uveitis, or multifocal choroiditis alone. Either one will be fine. Non-entity is pontic choroidopathy that's PIC, and then the multiple evanescent white dot syndrome that's MEWDS, and then you have this very peculiar condition called acute posterior multifocal blacoid pigment ampliopathy, that's MP, and then you also have serpiginous choroidopathy. So I listed here 1, 2, 3, 6 different entities. There's a couple more that you can add it to it. All of them in general have put it to this condition called white dot. They're not really white, they're more like creamy, but for pattern way we call it like that, and this can be part of this thing. And most, if you ever go to the retina meeting or a macular society meeting, during the case conference, many of the cases that are being presented will be one form or other of the white dot, because it's always caused a lot of headache and thinking here. So let's start with this case here. This is a 68 years old Caucasian man with a prostate cancer in remission, vision of 2100, 2080, no idiopathic and a fun part of eye. This is his fundus. So 68-year-old white man with blurry vision here. What you see here is obviously bilateral involvement with multiple chorioretinal aspects from this aspect. Some are bigger than just white dot. This is more whitish lesion of this aspect here. This aspect. And this is the fluorescein angiography here with this pattern of that. So name something that this cannot be among the white dot.
Birdshot.
What do you mean? Could it be a case of birdshot?
No, unlike
No.
the MEWDS.
So that's something you can rule out right away. It's on a differential diagnosis of white dot, but really it's not a birdshot here. So this is something to really consider something else along with this aspect, right? So yeah, that's what we would do in this case. Is we look at this aspect up here. It looked like a pattern of more like a snake moving around. So what can this be in here?
Serpiginous.
Serpiginous, one of those things. What other thing can it be? Jose, what else can it be? When you think of serpiginous, what other thing can be in that differential diagnosis? MP, and what else? What happens if you don't like one, you don't like the other, you marry two of them? Serpiginous, that's another one, and that's differential diagnosis as well too. So when we don't know things, we just mix them together and we add them together with the aspect here. So the likely diagnosis here, we can call serpiginous, we can call this MP, or we can call it serpiginous choroiditis. We can see you guys, the group of us, we sit around, we have nothing to do, so we come up with a name and we call it that. That's the posterior scleritis. So Dr. Wong has shown you some of this aspect. This will be a long-term chronic of this aspect. So far, I've mentioned you 4 different entities here that are looked in the back more of it. Yes? That's MP. That's acute posterior multifocal. That's on the differential there as well, and there. By the way, don't take note. All of this thing will be sent to you. I just, at least for this talk, I didn't want to send ahead of time because I didn't want people to look at the slide, but rather to look at this up here and both there. But all of this will be sent to you in there in this thing. So in addition to these 4, at least consider so far conditions here, to narrow it down even further, if you have to look at infectious causes of these, what are some of the possibilities that this can be infectious? And if so, what are the 2 or 1 condition that when you think infectious, what infectious etiology could give this right picture?
Tuberculosis.
So TB is 1, what else?
Syphilis.
Syphilis will be possible. Usually they're not that pigment that obvious in this thing like this. So certainly it's possible, but usually doesn't give you this much pigmentation. TB is definitely correct, choroiditis aspect from there. So toxo and TB are two of the things that we can do, especially multifocal toxo as well. So even though it's on the Y dot and truly TB is not a that different diagnosis, you definitely should, if you have to think of broadly for this aspect, that's what you would do. So the question of serpiginous or MP or impingement is a way that we look at, we gather the different information and we put that together. So as far as the MP go, MP may be slightly younger patients, where serpiginous is more than elderly. The FA and the ICG patterns of this aspect can sometimes help you, although I cannot always rely on them because it depends at what stage of the disease will you have that. And then the initial clinical symptom as well. The difference would be the association with some disease. So which of these two has associated with cerebral vasculitis? This is a classic all-cap board question. Which of these two would most is associated with cerebral vasculitis? MP. That's the correct answer, and you will see that. So you have 3 times to take your all-cap and then 1 time to take the board. So of those 4 times that you're going to do this exam, 1 year you're going to see this question. I remember that myself, and then you see it later on too. The prolonged clinical course. Which one have prolonged clinical course? Serpiginous, because MP usually disappear now, but the therapy and the prognosis are also quite different between the two, and that's why we take the time to try at least to learn them to do this aspect there. So impingement choroiditis is when you have overlapping features, not completely too long, it's not completely too short, and yet it's still progressing of this aspect from there. So some of these photographs come from our colleague Lee Chen-Po from Northwestern Chicago and David Sarabas from UCLA here. So just some of the images that we share. So the different phases of MP can be quite protean in this aspect. Sometimes they look like a creamy big lesion. Sometimes they're multifocal of this nature out of this lesion. And sometimes it's much more isolated, like 2 different parts in this upper right end. Or you can have this different aspect of that here. So these are different phases of MP that will appear throughout the course of the disease. The treatment for MP in general, when we actually present a case of treatment, if you present a case of grand round, of MP during grand round, then if you really think that it's a MP, then in general, no treatment is needed in most cases. At time when you get really nervous, because vision in MP can drop at lower 2400, so when you get really nervous and the team say, okay, let's give it a course of corticosteroid, may be considered, but there's no really documented data in the literature to really show whether it's actually improved or not improved. So if you must and you don't feel comfortable, you must think that you treat somebody, then a course of corticosteroid there. Although when you present it during grand round, some of the attendants will say, well, if you watch the patient, it will also get better as well too. So that's the part there. The vision often remains stable, and then the majority of the patient will recover a vision 20/40 or better in this aspect. Serpiginous, on the hand, is the completely opposite of that. For serpiginous, it will be necessitated that you treat the patient, and in general, for the treatment of it, it's actually quite aggressive. If you don't use an alkylating agent like Glanbrosil or cyclophosphamide, then you use a combination of cyclosporin, azathioprine, and prednisone. If you choose to use an alkylating agent, then you just down to 2, usually cyclophosphamide plus a prednisone in this aspect here. Now, Mitchell Franchek from Ohio has produced some of this data, and he indicated that sometimes perhaps you can also add a Bactrim to this regimen as well. And if you present a case like this to our colleague from India, to them, you need to rule out TB first. So by default, this will be considered a case of TB choroiditis unless proving otherwise. So it depends what region of the world you're coming from, and you can present with that. But a lot of this serpiginous, that truly serpiginous in our country, because we don't see them, we did not see any evidence of TB. When it's presented very similar in a country like India or Bangladesh, it would be considered TB for this aspect there. So the prognosis is a lot worse for serpiginous and can be quite progressive and medically resistant. The vision is quite guarded if not managed properly. So CMV may occur, leading to central vision loss. Otherwise, the lesion that you see there will encroach into the foveal center. So when you see this patient, this is very, very, very critical that you actually document with photo and you look at the photograph very, very carefully to see if the edge of the lesion has progressed into the foveal center or not. If it is, then you need to escalate your treatment, because if it's going to the fovea, it's irreversible. You usually cannot recover it back. So 5% of the patient, 2200 or worse in both eyes if you don't treat it. So this is the man here, Caucasian man I saw many years ago here. So he has blurry vision in this aspect where I present. And so the diagnosis here, I make a Serpiginous Choroiditis. So here's the challenge management. So I started him on prednisone and cyclophosphamide using the two-agent approach. He's unable to tolerate the cyclophosphamide, this aspect from there. So when we change him to the triple agent with prednisone, cyclosporin A, and mycophenolate mofetil, he's also unable to tolerate that also too because of the hypertension that he suffered from the cyclosporin A with this aspect. So now we cannot, we did not have the two agent, we cannot use cyclophosphamide, we cannot use the T-cell inhibitor, we cannot use this. So as a third line of therapy, what other thing we can use in this patient?
Rituximab.
I'm sorry?
Rituximab.
Rituximab. So rituximab, as you heard from there, beyond the cause of this aspect, I actually have a lot of side effects from rituximab, so I tried to avoid that. So that anti-CD20 in this aspect here. This patient basically could not tolerate systemic therapy. That's the problem with him. He's about 70, and remember, he has the history of prostate cancer, so he already was weak to begin with, so he could not tolerate systemic therapy, and therefore, intravitreal would, you think it local, that's fine, but intravitreal would not solve the problem because that's only an intermittent treatment and you want a chronic control of this aspect, right? So in this case, we actually put a fluocinolone acetonide implant. This is an era before the insert was available, so we put the implant into the eye and we actually did bilateral for that. Again, this would not be my first choice, and I did not do first choice. It's only the third option I had because the patient just could not tolerate systemic therapy with this. So 2 years after presentation, this is him 2040, and then 2 years after and this aspect from there. So his vision remained quite good. Of course, it comes with the significant adverse event associated with the steroid implant. He did have worsening in cataract that need to be removed. He also have intraocular hypertension that we need to follow as well too. And so to this aspect, but this is not the standard of care in general when you first present. If you have to take the oral board and they ask you the case the patient is, you should not say you put steroid implant in as first line because that would not be the idea. And so, but if they cannot tolerate systemic therapy, then you would go with that aspect there. So let's start with the next one. So this is a 26-year-old Caucasian woman. I actually have been following her now for 10 years, and she's been following me from Baltimore to the Midwest and now to Palo Alto here, and she currently lives in San Antonio. So she's a woman who with blurry vision, no medical history, moderate myopia, and this is her exam. So with this, the diagnosis is?
Mute.
I'm sorry?
Mute.
Mute? No. So in mute, you would have you would not see this much pigmentation here. So look at the history again. Woman, myopic.
PIC.
PIC. So that's pontic choroidopathy. That's very classic. That would be fair to ask on an oral board as well. So the patient's a woman, she's myopic, and this with the lesion mainly constrain the posterior pole with this aspect from there. Both are affected, although the right eye is much more than the left eye. 2013, 2020, in this aspect here. This is the fluorescein angiography for her, this aspect. And so that's the diagnosis. So what about this one? This one is a 24-year-old man with blurry vision, hypertension, 2025. He's from Philadelphia. In this case here, so this is the case that he had. Okay, so keep your thought there to think what this may be as well too. Okay, and look at the third case. This is a 32-year-old woman with mild myopic who complained of blurry vision, and this is her case. So you have 3 cases in a row of this aspect from there, somewhat blurry vision for this patient here. So you have the first case on the way in your left there, that's the one I mentioned, right? So that's the case of PIC. What about the second one and the third one?
They are also PIC.
I'm sorry?
They could be PIC too.
They could be PIC too, second one. What about the third case?
Is that azole?
Azole is usually much more changed in the peripheral retina within changes. So these two are PIC, both of these. One is the woman and one is the man. Case in that, just to illustrate that PIC can also occur in men as well, although the course is much more aggressive. The third one is mute. This is the case of mute because the lesion is much more subtle and it can also disappear as well from this aspect. And so the other condition, one could say that could it be a case of multifocal choroiditis as well? So that the lesion stay within the posterior segment. To me, and because this is a clinical entity, one cannot present a case of PIC with lesion all over the peripheral retina. So that usually helps us to distinguish between PIC as well as in terms of the multifocal with this aspect. So by definition, at least many of us agree that for PIC, it usually resolves within the posterior pole here. So MEWDS is a term that Dr. Lee Chen-Po is famous for. That's how he first described it. This multiple evanescent white dot syndrome, first described by who knows proceeding, who's proceeding. Okay, one day hopefully you can apply to a grant, either the Career Development Award or one to the NEI. So in case of the ask, so Poseidon is currently the director of the National Eye Institute. And so that's the name should be there, and you would see him formerly from Michigan, well known for retinal degeneration, but he also described this case in here at that time, 1984. And then the blind cross enlargement was then described, and then throughout that, since then, Dr. Yunussi, Dr. Spade, and Carlos Pauzio from London have also published different pattern of this aspect here for MEWDS. It's a very peculiar condition whereby the lesion appeared and it would then disappear. That's okay, he's tired, so can be congrats for a little bit. So this is a case of MEWDS. So you see multiple different spots in this aspect here. David Serapos from UCLA has sent this picture here from this group. And you may see some of them, and then it would also disappear. That's why it's the term evanescent here. But on funded autofluorescence, you can see the pattern of hypofluorescence in this aspect there that can make you there. And that pattern will change as well because it will not stay constant. Funded autofluorescence can be helpful, but that diagnosis cannot. If you see that it becomes pigmentary changes later on, then it probably most likely not be a MEWDS case of this. PIC versus MCP. The similarity is that they both have present of yellow-white spot that can become pigmented with time. The difference is the location, the lesion. I mentioned PIC, in my opinion, is much more in the posterior pole compared to the scattered distribution. And then the presence of iridocyclitis and vitritis is definitely not a PIC thing. PIC, by definition, in general, we do not see vitreous cells or anterior chamber. You cannot have iridocyclitis if you consider PIC. So if that's the case, then it's more likely a case of multifocal choroiditis and panuveitis. And then the clinical course and the prognosis is a little bit different as well too. So for PIC, the visual prognosis is a little bit guarded if not treated, but otherwise you will be able to see it. So Adam Gerstenfeld, when he was a student at Hopkins working with us, he put together a series of 75 patients who have PIC in there, and the onset of the two reasons why PIC patients lose vision are two. One is the formation of CNV. The second one is subretinal fibrosis. Those are the two complications that lead to vision loss and PIC in this aspect there. For multifocal, for MCP, it's a chronic recurrent course, and the visual prognosis and the permanent vision loss is also very high if you don't treat it with a long-term course of treatment to prevent the complication from that aspect. So both of these have been treated. MCP in the past, we've always been treated. When I graduated from fellowship, we did not use to treat PIC, but then we begin to do the study and we start to look at it, and we see that the incidence or the frequency of recurrence of the CNV or reappearance of CNV tend to decrease when we treat the subject. And with that, we're able to now start treatment. If you have seen evidence of progression in PIC, then you would treat with that. So observation, I say PIC, if you first time you see the patient with PIC, you may decide to observe, which is totally appropriate. However, if you see progression either in the lesion or in the term of the CNV, then definitely it would be required to treat. MCP, on the other hand, usually we start to treat it from the first time we diagnose patient, especially if we see that the evidence of active disease on fluorescein angiography or on OCT or whatnot with that there, from that aspect.
If you choose to observe in the PIC patient, how long, when should that follow-up be?
Sure, so I see, so that's actually a good point. So I see the patient every 3 months. Now, when our retinal fellow rotate with us, when we think with them, then they see my patient, they say, so they always call and they will say, that's when the patient did not show, they come back, the patient come back and say have blurry vision. They don't see well, but on fluorescein angiography, we don't see anything in that aspect, so it's probably just symptoms. So that's actually not correct. So patients with this type of thing, they're actually very sharp. So to follow patient with PIC, you don't necessarily look for the fluorescein changes, you look for the change in the OCT. You look at each of those lesions because those lesions can grow and become there before they develop leakage on fluorescein. So if the patient say that they're symptomatic, you should definitely evaluate the patient and look carefully for this lesion there. Yes?
So the lesions on OCT within the RP and the ISOS instructions that I showed earlier, those could, we have seen in the PIC patients that they almost always perceive the fluorescein angiography changes in that same region by 6 to 8 weeks, and in some cases even 12 weeks. So that's why the OCT becomes very important.
Yeah, you look at the lesion and you document it carefully on OCT. We are familiar with the spectralis divide. Okay, so let's say you have the spectralis in your clinic and then you label the lesion, they give you the cut and you can tell, how many sections with lesions, this because then you can go back and follow that very closely with that there. So the case one here, this is a woman one, so we managed to, with her with mycophenolate and she's maintained with that, and now I've been following her for 10 years, now actually 12 years now. During this course, she was able to stop holding back and then have 2 children during the course and now been back treatment again. And vision so far, we've been maintained on treatment with this. The case of the man from Philadelphia is a little bit more difficult, at least in my opinion. The patient with PIC who are women in general, the course is less aggressive than a man. When a man has PIC, for whatever reason, it's much more aggressive and usually lead to more damage. So for this patient here, I've been struggled to maintain him, to treat him properly in that. But again, also a PIC patient too. This are PIC and then mute, which is here you will see different pictures. And then third case, mute, the lesions are not at pigmented and they're not as obvious as patient with PIC. So that's what we do in that. And mute, the lesion often not pigmented. The prognosis is recovery in 2 to 10 weeks. And the term that you will see on the basic academy course, and also there would be a Kushma-3 description of this. So if you see the term on your OCAP and they say that the pattern is described as a Kushma-3, the patient may have a prodromal condition and then have this visual symptom, that is more likely of a mute case in that aspect there. And our condition mute before after MCP, that's what they would describe. No known therapy now for it. Truly, if it's mute, you don't need that. So let's move on to the next set of cases. This is a 69-year-old woman with arthritis, 2040-2025, and the diagnosis. So this is an elderly now patient. When you have an elderly person who present with this white dot type of thing, 2 things should come in mind.
Lymphoma?
One of them is intraocular lymphoma, that's correct. What's the second one?
MEWDS?
Less likely will be Birdshot, okay? So just like you seen before, when you have an elderly type of patient with multiple yellow lesions like this, definitely you think of lymphoma, that's definitely the case of two. The other thing would be, that would be Birdshot, because Birdshot tend to affect much more elderly people group here. So 2040, 2025, as you can see in there, the fluorescein angiography doesn't necessarily light up on those lesions yet, and some lesions are more pigmented than the other. That aspect from there. So the diagnosis here, that's the first case. This is the 62-year-old Caucasian woman with hypertension, decreased vision, 2060, 2025, no AC reaction, and this is that present there as well too. So in this particular lesion, you also see multiple yellow dots. So what do we see in the right eye there? What is that? What is that white thing that light up? I'm sorry?
CNV?
Yes, so that's the big net there. So this patient came from DC, and this is the big net that she had there, and there's leak a lot in that eye, the right eye there. So this is this 2 cases, and then this is the third case. This is the African man with blurry vision, 20/20/40, and this is this case here. So this lesion right away is different than the other one, right? It's much more discrete. It's multiple. It's something coalesced together in this aspect here. So for this particular case here, this case is Birdshot. This case in MCP cases, they're much more scattered around. And the third case is also a Birdshot, but Birdshot with CNV here. So what is the leading cause of visual loss in patient with Birdshot? That would be another OCAP question.
CNV?
C what?
CNV?
CNV?
So
Choroidal neovascularization? Okay. Final answer?
CME.
C what?
Sister
Cystomacular edema. Okay, that's fine. So yes, that would be fine. So that is that's appropriate. So CNV, corneal neovascularization occurred, yes, in Birdshot, but less common. So it would be the macular edema that will lead to the visual loss in Birdshot in that spectrum here. A lot of work on this coming out from Baltimore, and they have shown that that is the long-term cause of visual loss in this group here. So when you look at MCP and MFC versus Birdshot, CME is the leading cause of the visual loss there. The treatment for Birdshot is that the steroid alone definitely is not appropriate. And throughout the year now, a number of the regulatory body and a lot of the group in there, including the International UVS Study Group, American UVS Society, the International Ocular Inflammation Society, a number of these have come out with recommendations. So for this type of treatment, you definitely cannot use steroid alone. And I mentioned that so that you would be aware, so that if you come across this type of patient during your career, definitely either you treat it yourself or you get management. Whatever you do, don't just treat them with steroid. In case the case then end up with complication and you have to go and defend yourself in front of a court, then you will not have enough data to support just to use the steroid alone. So keep this in mind and you manage this type of patient in here. So immunosuppressive have definitely, immunomodulatory therapy has definitely been shown to decrease the inflammation, decrease the risk of developing macular edema here with this one. So following up, monitor the patient with Birdshot. What's the one thing that you should do?
Amsler test.
Amsler test would not be specific enough. So
OCT.
following patient with Birdshot.
OCT, visual fields,
Which one would be OCT or visual field?
OCT to monitor like CME.
Well, CME you should hopefully be able to see on thickness too, but that's fine. We grew up in the era we do that. But how do you monitor the progression of the Birdshot? If you have to go to court and they show up your paper, they will say, during the last 5 years, Dr. Malini, you have or you have not done this to see the progression. So one of them is visual field. What else did the American Academy Practice Pattern recommend?
ERG.
ERG. So to monitor patient with Birdshot properly, you need to have this document on your chart. You cannot just say, I did the fluorescein, I don't see anything. By the time the lesion in Birdshot become pigmented, that is too late already. So actually, when the cases that I was involved in involved the patient, by the time they develop color vision loss, that's when the retina specialists get alarmed and then send it to us to this aspect from there. So in a part where I share both retina and uveitis, that's where we always ask our colleagues to be careful with this because you cannot just wait until fluorescein changes. For patients with Birdshot, you need to have a measurement that shows global problems. So it would be, for example, ERG is one. If you don't want to ERG, you can do visual field, but you have to document it. And then color function is important as well with this group there. Okay, so these are things that you document, and then you can look into the American Academy practice pattern, and these are things that we recommend to be done. Yes?
For Birdshot and MCP, do you, like you mentioned in Serpiginous, you have to use 2 immunomodulatory agents? Is it the same for Birdshot and MCP?
For Serpiginous, if you use 2, one of them should be an alkylating agent, like chloramphenicol or cyclophosphamide. If you don't want to use alkylating agent, and then you use 3, so usually azathioprine or mycophenolate plus cyclosporin plus prednisone, at least initially to put the disease in control. For Birdshot is usually just 2, so one of the anti-metabolites plus steroid as well too. But of course, it depends what stage of the disease is, and you manage them active, and then once they're stable, then you take it down. Okay. So the management of this, so for Birdshot, I use cyclosporin and methotrexate. For this particular one, which is MCP alone, once it's stable, I use mycophenolate there, and then the other one, I use mycophenolate molecule, and then I also add the bevacizumab to that as well. So overall, this is the white dot syndrome here that I mentioned to you. This is only 6, but you can certainly add some more because sometimes that may not all fit in here. And it's very important that we recognize it. It is fine if you want to think of it as a spectrum or you think of different entities. It's just a matter of you recognizing the potential. For example, an elderly person coming in with this aspect from there. So you might click and say, okay, could it be Birdshot or could it be the IOL? If it's either one, then you say, okay, how can we move forward further? An elderly person coming in with this yellow lesion, if you don't think of IOL, then it's not very good because then you may miss a very severe diagnosis. On the other hand, if it's Birdshot, then you know you can treat it, then the patient would not lose vision based on the macular edema here. Okay, so common shared feature is they're usually less than 50 years of age, except when it's Birdshot. In many of the unit entity, the females tend to have predominance in a number of these conditions here, and most of them are bilateral except mute. So on your OCAP, if you have 4 choices, which of these following are more likely to be unilateral versus bilateral? And one of the choices is mute, and that should be the correct answer because they tend to be usually unilateral versus bilateral. There's that back from there. Viral syndrome tend to go among mute and also MPPE as well. So a lot of the patients have that condition before. So in summary, this is the heterogeneous choroidal inflammatory disease with overlapping clinical feature. Infectious versus autoimmune, we don't have a clear aspect. We do know that the initial presentation is usually quite inflammatory, so we use that to control. And it's totally fine. Once you get that under control, you may add, for example, you may add an agent like, for example, bacterial to help to manage your TSR. So this aspect. And discrete entity or continuous single disease. So we know we don't have a clear answer yet. We know to manage many of these, but we don't necessarily know the exact feature for this. And the differentiation here would be the natural history, well, also the lesion morphology and the evolution over time, and then the predictive visual outcome for this patient is different. Any question? Clear? Good job. This is when you rotate with me, then will be perfect now. See? Okay, so let's move on to the second topic. John feel really attacked now because I know him so well, so this is a problem here. Okay, so let's deal with this. Okay. So now we're going to go